After taking the patient's history, measure her visual acuity, which tests cranial nerve 2, the optic nerve. To test distance vision, have the patient cover one eye and look at a Snellen chart that's 20 feet away. Ask her to read the smallest line in which she can identify all the letters.
P-E-C-F-D.
Can you read anything on line 6?
Maybe, but the letters aren't clear.
Okay. Now cover your left eye with the card and tell me which line you can read clearly.
Line 5 again.
Can you read that line backwards?
D-F-C-E-P.
Now we'll do this again. Put your glasses on and cover your right eye with the card.
That would be line 8.
If you test the patient with and without corrective lenses, document the readings separately. Record the patient's visual acuity as a fraction. The numerator is the patient's distance from the chart, usually 20 feet or 6 meters. The denominator is the distance at which the average eye can read the line. For example, a reading of 20/25 means that the patient can read at 20 feet what most people can read from 25 feet away. In adults, average vision is 20/20.
Are you ready to play the E-game? Yeah. Good. Okay, Mom, if you could cover up one of her eyes.
For a child or an adult who doesn't read English, use a Snellen E-chart to test visual acuity.
Good.
While you stand at the chart, have the child point her arms or fingers in the direction of the legs of the E.
That's
You
right.
may need an assistant, such as the child's parent, to help her cover one eye.
Now cover your
If the
right
patient's
eye with the
distance
card.
vision is less than 20/20,
Your left eye.
have her hold a card with a small pinhole over the uncovered eye and read the chart again. If visual acuity was reduced by a refractive error, this should improve acuity by at least one line.
T-E-C.
Next, test the patient's near vision with a Rosenbaum pocket vision screener held about 14 inches from the eyes.
Cover your right eye with the card and read the line with the smallest numbers that you can see clearly.
Normally, near vision is also 20/20 in both eyes, which should be tested separately with and without glasses.
428-739.
Good. Now take off your glasses and we'll try it again. Now I'm going to test your peripheral
Next,
vision.
estimate peripheral vision with the confrontation
Look
test.
directly into my eye.
Position yourself
You're gonna
1
cover your
meter
right
from the
eye.
patient at
I'm
eye
gonna cover
level.
my left eye.
Have her cover her right eye while you cover your left eye.
Now, what I'm going to do
With your arm fully extended midway between you and the patient,
what I want you to
move
do
your
is
fingers
tell me as
in
soon as
from
you
the
can see
superior,
them, okay?
temporal,
And remember to
nasal,
look straight
and
ahead.
inferior fields. If you have no vision problems, you and the patient should see your fingers at the same time.
Now.
Good. Now we're going to switch eyes and we're going to try it again. Remember to look straight ahead.
Usually this occurs at about 50 degrees superiorly, 90
Good.
degrees temporally,
Now.
Good.
60 degrees nasally,
Now.
Good.
and 70 degrees inferiorly. Next, examine the
Now I'm gonna
external
look at the
eye
outside of your
structures.
eyes.
To start,
Relax,
inspect the eyebrows,
straight ahead.
noting their
eyes
size,
open.
extension, and texture. The hair should extend beyond the temporal canthus and should not be unusually coarse or thin. Then inspect the orbital area, which should have no edema, puffiness, lesions, or sagging below the orbit. In an older patient, you may see puffiness caused by an age-related loss of elastic tissue. However, you should not see periorbital edema. In a newborn, the eyelids may be swollen or edematous from birth trauma, but should have no inflammation or drainage. Also inspect the eyelids.
Now, could you close your eyes for a minute, please?
When lightly closed, the eyelids should have no fasciculations or tremors, and there should be no flakiness, redness, or swelling.
Now open your eyes, please. Good, thank you.
On both lids, the eyelashes should have no inflammation or crusting. The eyelids should not be inverted or everted, and the lashes should turn up in the upper lids and down in the lower lids.
Now what I need you to do is open your eyes.
Also, the upper eyelids should cover part of the iris, but not the pupil. The lids should be able to open widely and close completely, with no drooping or lid lag.
Okay, now I'm going to palpate your eyelids. Close your eyes for me.
Next, palpate the eyelids, which should have no nodules. Also, palpate the eyeballs, which should feel firm but not hard.
And now I'm going to check the inside of your eyelid.
Then inspect the conjunctiva of the
And
lower
look up for me,
lids.
please. Good. And I'm going to check the other eye.
When the lower lid is drawn down, the conjunctiva usually appear clear and free of erythema and exudates.
Let's see if I can find out what's irritating your eye. I want you to just relax. Look
Inspect the upper conjunctiva only if a foreign body may be present. While the patient looks down, gently pull the upper eyelashes down and forward, and evert the lid over a cotton-tipped applicator. After inspecting the upper conjunctiva, ask the patient to look up while you press down against the eyelid.
Now, look straight ahead while I examine your corneas.
Next, inspect each cornea by shining a light tangentially on it. The corneas should be clear and have no blood vessels. In a patient over age 60, you may see corneal arcus or circus senilis, an arc or complete circle of pale lipid deposits at the periphery of the corneas.
Now, Mrs. Franklin, I'm going to touch your eyes with this cotton.
Also assess corneal sensitivity and cranial nerves 5 and 7, the trigeminal and facial nerves. The expected response is blinking.
Okay, let's try the other eye. Good. Now I'm going to examine your pupils.
Next, inspect the irides, which should match in color, and observe the pupils, which should be round, regular, and equal in size. Then dim the room to test the pupil's response to light.
Mrs. Franklin, I'm going to check the reaction of your pupils to the light. Just look straight ahead.
When you shine the light in the right eye, the right pupil should contract directly, and the left pupil should contract consensually. When you test the left eye, the opposite should occur. Also check for afferent pupillary
Now, this is a
defects
slightly
with the
different
swinging flashlight
Look
test.
straight ahead.
Shine the light in one eye and then rapidly swing it to the other. When the light crosses the bridge of the nose, the second eye should dilate slightly. When the light enters the second eye, that pupil should constrict as much as the first one.
We're going to do another test. First, I'm going to have
Next,
you focus on
test the
wall
pupils
over
for
my
accommodation.
Then I'm going to have you focus on my finger. Look at the wall over my shoulder. Good. Now look at my finger.
The patient's pupils should constrict when she focuses on an object held about 10 centimeters from her nose.
Good.
During all corneal tests, estimate the pupil size. When dilated, pupils may be up to 6 millimeters. When constricted, they may be as small as 2 millimeters.
Now I'm going to look at your lenses.
Using a pen light, inspect the lens, which should be transparent, and the sclera, which should be
Now I'm
white,
going to look at
and
the white
visible
of your
above
eye.
the iris only when the eyes are wide
Your eyes
open.
as wide as you can. Now I'm going to examine your tear ducts.
Continue by inspecting the lacrimal glands and palpating the orbital rims near the inner canthus. The eyes should be moist without excessive tearing. The puncta should be pink and appear as slight elevations with no enlargement or discharge. Next, assess the extraocular muscles in the 6 cardinal fields of gaze.
And I'm going to ask you to follow my finger with your eyes, okay?
The patient should display full movement, which reflects proper functioning of extraocular muscles and cranial nerves 3, 4, and 6, the oculomotor, trochlear, and abducens nerves.
Now follow my finger to your extreme left as far as you can.
In the extreme temporal positions,
Now to your right.
expect a few beats of horizontal nystagmus.
Now I want you to follow my fingers as far up as you can and as far down as you can, again without moving your head. Just follow with your eyes.
The eyes and upper lids should have smooth, coordinated movements. Next, perform the corneal light reflex
Start with
test.
finger.
At a distance of 30 centimeters from the light, the eyes should reflect it symmetrically, showing balanced extraocular muscles. If the light is reflected asymmetrically, do the cover-uncover test.
And you're going to stare straight ahead at my ear.
Look for any shift from a steady, fixed gaze in the uncovered eye. Then remove the cover and watch for movement in the just uncovered eye. You should see no movement in either eye. Finally, perform an ophthalmoscopic examination, giving the patient short breaks to rest her eyes from the bright light. If you wear glasses or contact lenses, you may leave them on for this examination. Patients should remove glasses, but may leave contact lenses in place. With the ophthalmoscope in your left hand and its lens set to 0, use your left eye to examine the patient's left eye, starting with the red reflex. For stability, place your right hand on the patient's forehead or left shoulder. Then direct the light at the pupil from 30 centimeters away. As the light hits the retina, you should see a red reflex with no black densities.
Now I'm going to come closer to your eye. Keep looking straight ahead.
Then approach the eye slowly, adjusting the ophthalmoscope lens with your index finger to focus on the details of the fundus or retina. If the patient is myopic or nearsighted, expect to use a minus or red lens. If she is hyperopic or farsighted, plan to use a plus or black lens. In a light-skinned patient, the fundus may appear yellow or reddish pink. In a dark-skinned patient, it may look much darker. Whatever the background color, you should see no discrete areas of pigmentation except for crescents or dots at the disc margin. Because you can really only see a small part of the fundus at a time, use the blood vessels as landmarks. Blood vessels branch away from the optic disc, so you can trace them back to find the disc. Then follow the blood vessels distally as far as possible in each quadrant. The arterioles should appear smaller, brighter, and redder than the venules, and the arteriovenous crossings should show no nicking or other changes. Next, examine the optic disc, which should be sharp and well defined, and may vary in color from yellow to creamy pink or darker. Use it as the unit of measure for locating fundal lesions or structures. For example, this lesion is 2 disc diameters from the optic disc at the 2 o'clock position, and the macula is about 2 disc diameters temporal to the optic disc.
Now look directly into the light.
This brings the macula into your field of vision. The macula should look like a yellow dot, surrounded by a deep pink area, and should have no blood vessels.
Great. Let's give your eyes a moment to rest, and then I'll check the right eye. Let me know when you're ready.
When examining the patient's right eye, switch the ophthalmoscope to your right hand and eye. As you did with the left eye, check for a red reflex, and then inspect the fundal structures, noting any lesions or other unexpected findings. Healthy eyes require the cranial nerves, extraocular muscles, and all eye structures to function properly. And you need expert history taking and examination skills to assess all of them. With your examination findings as a roadmap, you can help your patient stay on the path to eye health or obtain the eye care that she needs.